And we come from the space where we believe that HIV risk is driven by vulnerabilities. And so we choose not only to focus on populations that are at risk, but also on populations that are vulnerable. And a lot of our work with women and with young girls who are at high risk of HIV is because they are vulnerable, and we try to address that. And the groups that we work with in the vulnerable populations include men who have sex with men, youth, and youth means 15 to 24. And we also work with sex workers, and we work with people with disabilities, and then finally we work with survivors of sexual violence and survivors of broader violence. And where we started with this work was really coming from an HIV prevention perspective, looking at the fact that women who experience sexual violence are likely to be HIV infected, and women who experience other forms of violence are likely to be predisposed to risky behavior or be unable to negotiate their HIV risk. And it was on that basis that we started 5 years ago with a study on looking at how to provide post-rape care services, very specifically on gender-based violence, very specifically on sexual violence. And over the last 5 years, LVCT has helped provide results that developed the national guidelines on medical management of rape and sexual violence, being able to ensure that there was a model that could actually be brought to scale in a limited resource setting. Most of the models that we see currently are one-stop models that are really difficult to bring to scale in rural setups, in setups where health systems are weak. And so you're looking at how do you integrate services within existing public health institutions. And this model has also kind of been used to try and inform the ongoing WHO developments, because we believe that many settings are really pretty much similar to the setting in Kenya. And over the last 6 years, 5-6 years, LVCT has provided services to about approximately 14,000 survivors of sexual violence. But besides that, the other work going on beyond just sexual violence to broader violence against women. Last year we did a study where we looked at sexual exploitation among children. And I am not sure really how to put this, because it is not in the public domain of HIV, at least in the African or sub-Saharan African context. It is mainly in the Asian context where you see a lot of information on exploitation of children. And what we found was that children as young as 10 years old were, out in the streets selling, selling their bodies and being exploited. Many of them don't know about HIV or don't know about condoms, are completely unable to negotiate any of the services, obviously with older men, sometimes with younger men. And so these are really children who are being exploited through sex work. So part of our adolescent program has begun to focus on that. Our adolescent program is actually a self-branded program called the One-to-One Youth Program. We run East Africa's largest telecounseling hotline that is focused on the youth, and it's a private-public partnership between LVCT and Kenya's largest telecommunications program or provider, which is called Safaricom, who hosts the hotline. And the whole idea is to be able to utilize information, to be able to utilize the rapidly expanding ICT and mobile phones and the availability of text messaging and the languaging around youth and youth mobilization to be able to reach young women and be able to provide them with, one, information on what it, first of all, telecounseling, which is basically the psychosocial support, but also information on where to go when they need services, which unfortunately are very few, so there isn't that many places you can actually refer people. And also to be able to provide them with opportunities to be able to ask questions rather than continue to get information from all these sources, which more often than not are really either misleading or unclear or false, which is where a lot of young people get the information. And so one of the projects that LVCT has been running is when we realize that young people, and particularly young rural girls, do not have access to these telecommunication gadgets and access to this telecommunication platform, which serves approximately 6,000 young people every month calling in, with about 95% of the calls complete. Young women from the rural areas just don't have the infrastructure for it. So we started what we call as a buzz, a little comic type pamphlet written in local language, Swahili, a little bit of English, a little bit of a mixture of both, which is sort of a language that has evolved among young people in Kenya. And it is this that we have been utilizing to be able to provide information and services to well over currently approximately 14,000 and hopefully young women every month, and we hope to be able to expand this to reach about even as many as 200,000 a month, if we can be able to do it. And how we know it's reaching all of these young people is because we are getting feedback and information and mainly questions. And the biggest challenge is pregnancy. What do young people do about pregnancy in our context, where there aren't preventive services, contraception is not necessarily available for young people, and when they're pregnant, they don't know what to do or where to go. And so that, in general, is sort of LVCT's work. It is really premised on focusing on HIV prevention, care and treatment, and sexual and reproductive health services. And we primarily work on the policy action side of things, but also on a lot of service delivery, which is part of what I have described today.